Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Winston. How are you doing today?
Very well, Dennis. Looking forward to this podcast.
Yeah, me as well. And today we're going to talk about the green whistle, methoxyfluorine, which is, I think, a common agent in Europe, at least in Australia and in New Zealand, you mentioned.
Yep.
And I think it's smart for any medic or any provider out there that is going to deal in multiple different countries, practice is trying to be more familiar with some of the agents that are out there. So you have vastly more experience with it. The only experience I have is seeing a picture of it. So what is methoxyfluorine?
Methoxyfluorine is a fluorinated volatile hydrocarbon, very similar to the modern volatile anesthetic agents like isoflurane, halothane, desflurane, sevoflurane. It was used up to 2005 as part of the hypnotic element of general anesthesia. Unfortunately, in high doses, and we can cover that later, there is a risk of renal toxicity because of the production of fluoride ions during its metabolism. So it went out of fashion, and the FDA banned it in 2005. But Australia and New Zealand kept on using it, in particular for pre-hospital care and on the burns unit. Just a few years ago in the United Kingdom, we welcomed it back. It went through trials to get it approved, and I was lucky enough to use it on the burns unit at Manchester in the UK, and it was nice to welcome an old friend.
Right. So, is it a strictly an analgesic? Has sedation effects? Like, I guess, where does it fit in the kind of spectrum?
So that's a good question, because what we're talking about is what we do for procedural sedation and analgesia in the field. So what methoxyfluorine does in low doses or sub-anesthetic doses, it's an analgesic, and in higher doses, it's an anesthetic. So
Okay.
For the rest of this conversation, when we're talking about its use in the green whistle, we're talking about sub-anesthetic doses, so the patient does not lose consciousness. It's
Okay.
the original BCA.
Right. So obviously it's kind of, at least just PCA in my experience, either the hospital, you have your little clicker, or if you have a dental procedure like your nitrous oxide, just go ahead and breathe in as much as you want. And when you feel good, then go ahead and take it off. And you can control it that way. But does this have effects on the opioid pathways, or like how does it actually achieve its effect?
Like most anesthetic agents, volatile anesthetic agents, we're still trying to find out how it works. Is it through working on the GABA receptor and the two-channel potassium receptor? Nobody really knows, but that's the current explanations for its activity.
Okay. And there's a bunch of drugs that are out there that we actually don't have any idea truly how they work. Like I remember at least like Tylenol for a very long time. Nobody actually knew why it did its thing, but it did it well. So how does this come packaged?
Okay, it's called the green whistle because in the package itself, it's got a mouthpiece that's green, hence the term green whistle. It's made of two components, a mouthpiece and an activated carbon-containing chamber. And the carbon reabsorbs the volatile agent during expiration. So you inspire and you expire with your mouth over the mouthpiece. And the idea of the charcoal is that it reduces the contamination of the atmosphere with methoxyfluorine. Now, that's just a theoretical problem, because when we're using it in the field, that is not an issue. But when we're talking about using it in close confined spaces, the worker, the clinician using it for prolonged periods of time, especially females in their reproductive years, can cause long-term risks of miscarriage. Those are kind of sort of general safety issues.
Yeah. And I know, at least my initial training, we were using like isoflurane and draw-over gas anesthetic, and that was definitely one of the concerns. Is you're carrying these bottles, and you're in a vehicle or something, and there's a leak or a crack, and everybody's going to sleep. But so again, kind of where does this fit? Is this like a mild pain, moderate pain, severe pain? Like what is this good for? If you're using it for burns, I would imagine it's a pretty strong agent.
To explain that, Dennis, I hope you don't mind me just talking
Sure.
briefly about what I call the procedural pain matrix. When you're doing a procedure, there are two elements of prime importance. How severe is the procedure going to be? And B, how long? Those are the sort of two basic things. And where I see methoxyflurane is for severe pain, for medium to long duration. So it's like a very flexible. When I originally tried to place it in the armamentarium, I would put it in the same levels of fentanyl IV boluses with midazolam. So I think in general terms, very good for pain, more than 4 out of 10. Patients awake, and the duration's anything between 30 to 60 minutes.
Oh, nice. And is that so one whistle will last that long?
Yes.
I mean, they're inhaling it, right?
If you inhale it continuously, it'll last 30 minutes, intermittently 1 hour. And you're allowed to use 2 green whistles at a time.
Simultaneously, or
no, one after the
in
other.
series? One after the other.
Yeah.
Okay. And then after that, that's when you start worrying about the buildup of fluoride?
Not really, because when you're looking at volatile anesthetic agents, its potency is measured in MAC, mean alveolar concentration. And the good news is that the green whistle is very, very much lower than the anesthetic dose. It is reckoned that the equivalent of 1 bottle is equivalent to 0.3 Mach hours, and less than 2 Mach hours, there is no evidence of biochemical evidence of renal damage. So there's a huge safety element to it. So you're not getting levels at which anesthesia are obtained, because the inhaler is so constructed, it only delivers 0.2 to 0.4%, depending on whether you stop the air entrainment port. Then you get 0.4. If you keep the air open, then you get 0.2%. So it's like a turbocharge that's already on the inhaler.
Yep. No, that makes sense. So obviously indications, severe pain, 4 or greater, and your duration is somewhere between 30 minutes and an hour.
Correct.
Or your procedural length. I would imagine with some kind of inhalation type agent, a potential contraindication would be some kind of respiratory involvement where they may not be able to breathe that in.
I think it's important because this green whistle comes with a wrist strap. So the idea being, if the patient overdoes it, it falls out. Now, the good thing about methoxyflurane, unlike nitrous oxide, it is quick onset, but slower offset. Why? Because it's very lipophilic. So when you take a breath in, the fat in the body absorbs it like a sponge. So when you stop using it, the elution of the drug from the fat into the bloodstream and then into the lungs for expiration, you don't get that sudden onset of pain. And in my younger days, when I first started using methoxyflurane in the late 1980s, one thing you could see by going into the recovery room, you could guess which patients had methoxyflurane as the volatile agent because they were comfortable.
Oh,
They
perfect.
didn't wake up screaming and shouting and stuff. So that's something
Right.
that I found really useful with methoxyflurane, because if they stop using it, they're not going to wake up screaming in pain. It's going to take some time. So from a ethical and a professional sort of use, I find it less swings and roundabouts than, say, with nitrous
Yeah.
oxide.
Yep. Yep. More of a steady state.
Correct.
Right. So as we talk about duration, what have you noticed the onset times being?
Well, the good news is that you tell the patient to take the first few breaths very gently. Otherwise, if they take a deep breath in with the first one, you're going to get that irritant effect, and you're going to get coughing and spluttering. So you ask them to start the first few breaths gently. It's a fruity odor. It's a colorless liquid, but it's got a fruity odor. By about 6 to 10 breaths, you get onset of analgesia. It's that quick.
Oh, perfect. Okay. So, um, so talk about onset, and then after that hour, say, how long until it really wears off?
It really depend on the habitus of the patient
Sure.
and the physiology, but generally speaking, from what I gather in the pre-hospital use, certainly in the UK, people have used it to say they can get the patient into hospital without too much trouble.
Okay. Maybe a half hour after they stop using?
Yeah, about half an hour after using it, they might start feeding the pain.
Okay, perfect. Are there any other are there any contraindications? Who would you definitely not want to use this on?
I think the first thing is anybody who's not completely alert and cooperative. Okay, so that applies to every PCA. If the patient's allergic to any of the anesthetic agents, if there's a history of malignant hyperpyrexia, if there is a known history of liver impairment or significant renal impairment. Now, you don't know that when you're dealing in pre-hospital care, but generally the older the patient, you're less likely to use it than a younger patient, ASA1, 2.
Sure.
Any position where there's an altered level of consciousness, cardiovascular instability, or respiratory depression. So very much like the contraindications to opioids, really, or any sedative agent.
Okay. I mean, renal impairment, liver impairment, altered mental status. To me, that would say somebody who's in shock. Maybe this is not somebody that would want to use this type of agent in.
Yeah, somebody who's cardiovascularly and respiratory stable, but you want to do something, a procedure that is going to be painful, but hopefully it'll be self-limiting. It's not going to be a continuous problem. I think methoxyflurane is a very good choice.
Would this be similar to like the fentanyl lollipops, as far as that type of patient?
Yes. I mean, this applies to all our PSA agents, really. For practical purposes, do not use it for inducing anesthesia, because that's not what it's made out to be. It's not licensed for children under the age of 18. Non-trauma pain, it's not indicated. Elective surgery, not indicated for obvious reasons. More than 6 mils, that's 2 bottles per episode, and not more than 15 mils in a week. That is the practical aspects of the situation.
Okay. How about environmental type factors? Does like temperature, pressure, do that affect the agents at all?
No, it doesn't, because the way the device is built is that you have air coming in from the environment, plus air going through the chamber. So, and the chamber, when you fill in, you pour the liquid around and swirl it like you do with a wine glass. And charge the canister. So, so there is not much variation so whether you use it at a different altitude and stuff, it doesn't seem to make any difference. It's quite
Okay.
versatile in that respect.
Okay. What other things? So you talked about, you being able to use it with your burn patients. What is your experience been with it?
I was the first one to introduce it into the adult burn unit at Manchester, and the first patient was a opioid dependent patient who had burned himself about 3 weeks previously, and he just loved the opioid based sedation techniques. He just loved it, and
Yeah.
we were quite concerned about it. But at the same time, we have an ethical issue of providing a good care, irrespective of the patient's personality, et cetera, et cetera. There are ethical issues.
Yeah.
And it just so happens that one of the reasons why procedural sedation is taken off in the world is that it's much cheaper than having an anesthesiologist at your side. So there was a huge shift just for cost's sake to try and introduce the green whistle into our unit. And when we used it on this guy, he was the physiotherapist was able to get all his fingers moving, which were burnt in the original injury, and he was able to get maximal movement of the contractures, which he couldn't do even with the opioid stroke midazolam combinations. And at the end of the procedure, I went about an hour later. I went to see him, and I said, "What was it like?" He says, "I don't know what it was like, but look, I can move my fingers."
Yeah.
So I think we have to be conscious of the fact if you use this the green whistle properly for what it's meant to be, and provided you can cajole or coax your patient to do it well, it is so satisfying. I compared to nitrous oxide, compared to my fentanyl midazolam regimen, compared to my ketamine regimen, I think this is certainly at the top of my list now. And it's light, it's easy to carry. The only issue is what you discussed earlier, if the bottle breaks or smashes up, but that's it. And the disposal is that you just put it in the plastic bag and dispose of it safely.
Okay. Because at least what I'm kind of envisioning, especially if I'm having to deal with like mass casualties or, some kind of clinic type situations where, maybe we're not doing full anesthetics, but we're just watching a lot of people. An agent like this, very simple. You can hand them out in some kind of controlled way, obviously. But they can kind of handle their own pain control.
Yep.
It will take their mind off of just laying there and having injections done to them. That gives them a sense of their own control.
Correct. And I think you raise a very good point, because in the 90s, one of the professors of anesthesiology at St. George's in London made a comment on PCAs. And he said, PCAs, this was using morphine, compared to regular IM morphine, is not better. But the difference for the patient's perspective, it's better because they've got control. So so going back to the green whistle, if you say to the patient, look, this is the green whistle, this is the wrist strap, this is where you put your finger over the hole to get a turbocharge, breathe gently to begin with, get the feeling of what it feels like so you don't cough and buck. Keep going, everything will be okay. I think you have to sell it. It's like everything. And I think the fact that it's a PCA, and I like the point you made about control, because that is patient satisfaction plus.
Yeah. And I mean, at least I've found anyway, if you give the patient control of their own pain control, their own analgesia, it tends to be a lot less than what I thought they would need.
Correct.
I think it's, something that's, it sounds anyway, very simple, very safe, and it can be used. I guess once you crack it, does it just constantly burn, or is it depending on how frequently are they blowing it?
Are you referring to the
The
speed
agent. Yeah.
Yeah,
Yeah.
it depends on the tidal volume, the respiratory
Okay.
rate, and whether it's intermittent or continuous. That's where the 30 minutes or 60 minutes per bottle comes from.
Okay. No, I'm just thinking, get somebody that's under control and they're like, okay, I'm fine. not gonna take any more tokes off of it. And they leave it sit for, 20 minutes and then they take another one.
Yeah,
They may not be able to get that full hour out of it.
Yeah, I mean, I think if somebody's just using it to get on top of the situation and they stop using a little while, the good news is they've taken a few breaths when they feel they need to. It turbocharges very quickly, so it's not an issue.
Okay, perfect. Whether it be just patient-controlled analgesia or the methoxyflurane specifically, is there anything else you would like, medics such as myself or any other providers in kind of austere environments to know about using this agents, using patient-controlled analgesia effectively? Things that we need to watch out for.
Okay, I think when you're choosing your agent in hospital, certainly the treatment and management of procedural pain is done badly because there's a huge volume that can be done under PSA in a hospital, and you can imagine the money bag holders want a cheap service, so it tends to be done badly. So the first thing I would say is, can you do basic life support, because that is just part of the thing? Can you manage an airway, all those kind of things? With that, then try and work out on your patient what is the status of the patient, ASA status of the patient. How long do you think you're going to take? Now, on the burns unit, to do a burns dressing change, a complex burns dressing change, it would take us anything up to 2 hours, 2.5 hours. Well, so I said to the nursing team, get all your dressings done, lay them on a trolley, keep them in the clean room, undo the dressings that are currently on, wash, bring the clean trolley in, wrap up. So you need to minimize. So if you're doing a procedure on a patient, especially if it's a complex one, get your kit ready so there is simultaneous synchrony between what you're doing and what the patient's doing. So that's the second. The third is knowing how long the procedure and how severe the pain is going to be. Now, as I've got older, I've realized the importance of psychological comforting. You mentioned it early on, the fact that PCA got control. Never ever say to a patient, I'm going to make you pain-free. You are going to be in trouble. State to the patient, I'm going to give you a technique that will make the procedure more comfortable for you to bear. Now, if the patient's pain-free, you're winning. But it means that when you have a little bit of a trough peak kind of situation, you're not to blame because you've been honest and said, look, I'm not going to say I'm going to get your pain to 0. I'm going to take your pain out of a score of 10, round about 3. So I use that kidology in all my patients, and I think it's honest because you've got to look after safety as opposed to offering something that cannot be delivered.
Right. I mean, one, you're providing analgesia, not anesthesia. So you can't make it 0 because that would be anesthesia.
Yeah.
And it has its own risks. Sure. So I think just being honest with the patient, being comfortable or like medically okay when the patient goes, ow, that hurt. Understanding I'm not doing this for fun. I'm doing this to make them better so that we don't end up having to do this, forever. Yeah. Right. We're taking a patient from where they are and getting them better. And definitely take advantage of, if you're going to do a procedural sedation or analgesia or whatever, you're giving an agent for the purpose of this procedure. Well, take advantage of your time and and don't spend it running around trying to find your Curlex. Get all that stuff done, have it, and just be efficient with your time.
Yeah.
That's where I see where a lot of nursing care things take forever, is because people aren't very efficient with their time and they don't plan out. I need to do 2 or 3 different things. Let me get all the gear for those 2 or 3 different things, and then just knock it out and get it done. Get the patient tucked back in and go on to the next.
Correct. I think that's so true. Thinking out the procedure in your mind before you start. And it starts with patient education, preparation. If you're lucky enough to have somebody assist you, making sure they are educated before you go into into the wide open. And it's all a question of experience. And you hinted a few minutes ago about what my favorite PSAs. There would certainly be fentanyl midazolam, ketamine by different routes, and methoxyfluorine. These are my 3 big do a lot, see a lot, and then you can pick and choose, because you're not going to get methoxyfluorine everywhere in the world.
Right.
But you may. But if you do have it, then it's in your armamentarium. So it's another bull to your arm.
Right. Absolutely. And it just falls in with something that you should be doing anyway, even if you're not using the green whistle. All right. Well, you have fentanyl. You have ketamine. It's just another tool to augment patient control, patient analgesia. I don't know. Is there anything else that we need to talk about as far as patient?
I think we've covered the main aspects. The pharmaceutical companies have videos on it.
Okay.
So if you log on to their websites, because the different companies have different geographical areas in the world.
Sure.
Just contact them. Certainly, I think if you're not using it, then at least have an idea, so that when you do go out with a multinational force who are using it, you at least have the basic knowledge about it. And I want to end on one statistic which really spooked me out. In 1995, in the UK, Queen and Charlton, in the journal Gut, showed that sedation kills more people in the UK than general anesthesia.
Wow. Okay. Why is that?
So what the point I'm trying to get across is, if you're going to do procedural sedation, especially on your own, especially out in the middle of nowhere, you have to have a mixture of 2 things: the theoretical knowledge and the practical experience. And the more you use it, and the more obsessive you are about maintaining that level of verbal contact with your patient in these. So you can be talking to your patients while you're doing the chest strain or putting a splint or whatever. Talking to the patient calms you, and it calms the patient, because they
Right.
just don't have the bleep of the pulse oximeter or other extraneous noises. They focus on the green whistle. They focus on what you're saying. It preoccupies them, and distraction is also part of analgesia and pain relief, because you give them confidence. They know they're in safe hands. So you need to be a good actor.
Yeah. And I think people, as a medical provider, a still sleeping, sedated patient makes me feel good, but that doesn't necessarily mean that's what's best for the patient.
Agree.
Yeah. Well, thank you, Winston. I always appreciate our conversations.
Well, thank you, Dennis, for inviting me, and I look forward to the next one.
Yeah, absolutely. Well, I'll think of one up soon.
Thank you very much.
Cool.
That's it for today's podcast. Be sure to go to our website, www.prolongfieldcare.org. Find us on Facebook, YouTube, Instagram. Subscribe and stay on the bleeding edge of combat medicine. This is Dennis for the PFC Podcast. Out.
Boy is waiting there for you.